What type of danger signs in prostate cancer would you highlight for men, that these 1, 2, 3, 4, 5 or 1, 2, 3 pointers that if you see are different for you, your sexual health and your reproductive health, you should look for a healthcare practitioner for further analysis?
So, well, I would start by saying, one, if you notice your urine stream is reducing in where it's going, then you need to get help. If you're noticing your sexual function is going down, you need to get help. If you have pelvic pain, back pain, chronic back pain or lower abdominal pain, you need to get help. Kesho ni tatu. No, unaniangalia.
So ni saa ngapi, doc?
8.
Sawa. I think we have paka saa 5, saa 6.
That's okay.
Sawa. So these are just like the pointers. So what's prostate cancer? How does it come about? Genetics, risk factors, non-modifiable, modifiable, signs and symptoms, early diagnosis, and like the morbidity and mortality based on different stages of the cancer. And the belief that cancer is a death sentence based on those mortality and morbidity studies. You're like stage 1 to stage 4. And then like the management process that you as an oncologist goes through when you're making that decision. It's tailor-made to everyone, but sasa uta-educate watu. Then for stage 4 na your mets, how bad is it? How has it been as your process as an oncologist seeing a patient with prostate cancer for stage 1 versus stage 4? Then recurrence for patients that have been properly managed based on the different stages, and the government role based on the number of cases and the number of case burdens you've seen in your practice. Unaonaje? So that would fit in 30 minutes.
There you go. So.
Yeah, what do you think, Elias?
It's rolling.
It's rolling.
Already?
Long time ago.
Sawa. Let's
oh my
get
God,
this.
you've located all those things I was saying.
Yes, sasa ni behind the scenes ni yetu.
Okay.
So, karibu sana Dr. Wanda. My name is Dr. Dimbil. Welcome to Laughing Lab Coats. Today we have a special guest, one of many. Karibu sana daktari.
Thank you very much.
I let you have the screen time kiasi ujiintroduce uchapiane na watu.
So my name is Dr. Wanda. I'm a clinical oncologist. I'm very happy to be here today. Creating awareness is one of the passions that I have, and I believe it's very important for us to talk about cancer and make it easy to understand so that everybody who's listening to us can understand what we're saying.
That's wonderful. I met Daktari when we were doing a talk about breast cancer with Spice FM. It was really informative. It really went great. We met a lot of great individuals during that time, and I was honored to meet you. And we just had an amazing relationship just from the start with our ideas of how we can educate the general public and how we can give back to our society. And that was last month. We had breast cancer awareness. This month is prostate cancer awareness. You as a specialist, as an oncologist, let's start with the basics. What is prostate? What is prostate cancer?
So it's very important for us to just start from the beginning. So we have the bladder, and then at the base of the bladder, we have a small walnut-sized organ called the prostate gland. So the work of the prostate gland is produce prostate fluid, and that is part of what comprises the semen, the fluid that nourishes the sperms. In between the prostate is where we have the urethra. So that's the tube that connects the bladder and you're able to pass urine. So that passes through the prostate gland. So that's what the prostate gland is. That's its function. It's only found in men. We don't have it in women. I think that's good for us to make that very clear.
Let's get that out of the way.
That out of the way, very important. So
now, there's another interesting fact that we actually discussed when we met.
Yeah.
The prostate, other than it being a gland that produces fluid that gives to like the formation of semen and like nourishes sperms, it also has nerve endings, and that contributes to our sexual activity as men. Do you think so?
Very close to the prostate gland, there's a nerve bundle that's around there, anterior to the prostate gland. And definitely, yes. And that's why one of the problems that is normally noted or many men have reported is having erectile dysfunction when there are issues affecting the prostate gland, just because of the proximity to the nerves that are around that area. So that's true. That's very true.
Interesting. So one of the signs that might manifest with prostate cancer or benign prostatic hyperplasia, which is a precancerous form of prostate cancer, is that someone might have problems with kusimamisha.
Well, yes, anaweza kuwa na shida ya kusimamisha ama anasimamisha alafu hawezi kusustain kwamba inasimama lakini baada ya muda mfupi inakuwa imeacha kusimama.
Hii kanairo tunaitanga 1 minute man.
Yes, so we could say that. I try to avoid that because it sort of makes the men think 1 minute. You know, you can kind of time that. So I'm like, let's not call it 1 minute, but maybe if previously you could have it for a longer duration, you notice you're able to sustain an erection for a shorter time, or you're unable to have an erection altogether. Normally the prostate enlarges with age. So as a man ages, then it will enlarge over time. Some of the things you'd notice is, because you remember we said the urethra is like a straw or a tube through it. As it enlarges, it can compress it. So I think boys, I'm not very sure, you'll tell me if I'm right. Boys at a certain age have a competition of how far they can pee. So you pee and you say mine goes farthest, yours is short, and it's sort of a game that goes on. So you see there's even a name to it. So you notice over time that you're not able to do what you were able to do perhaps when you were much younger, 10 years old or less. You notice that the power of the stream is getting slower. It's coming a bit closer. You have to stand closer to the toilet bowl, otherwise it drips on the floor or perhaps on you. And those are some of the signs of there is an issue compressing, there is a problem. So it could be just benign prostatic hyperplasia, meaning the prostate, there is no cancer within it, but it's growing in size. It has grown in size just because of age, not because of any problem. But also it could be an indication that there is actually a mass that is cancerous within the prostate that is compressing now the opening for the urine. True. Yeah.
Now Wakenya obviously watasema nini uleta hii kitu? Like what is the science behind it?
So I think that's a question every time people ask about cancer, and I feel cancer is multifactorial. There is no one size fits all. I wouldn't say if you just have this, then that's definitely you're going to have cancer. So it's multifactorial. However, there are definitely things that would put you at a higher risk. For example, there's some things that are modifiable, some that are not modifiable. Modifiable meaning you can do something about it. For example, age is non-modifiable. You cannot change your age, even if you'd want. Women, we try. Whenever we get past 20-something, we just remain with 21. I am 16, you know? So when you're asked to say, I'm 16, and we move on, and we are like, that's a story for another day.
You shouldn't even ask a woman her age.
But some people do ask, and as women try to talk about, they say I'm 16. So I think 16 is the magic. I don't know why we like 16, but I think it's because it has some sweet going to it, or the time we became women, or something to that effect. So age is something we can't change. Another thing we can't change is our genetics. So for example, if my close relative had it can't be mine. If a patient, so if a man's close relative had prostate cancer, then they'll be at a higher risk of getting prostate cancer. So you can't change your genetics, you can't change your family history. Other things that are modifiable is perhaps your exercise levels, your alcohol, cigarette smoking, just lifestyle modifications, ensuring you're eating healthy. That has been known. Avoiding radiotherapy maybe, or exposure to radiation, be it at work or be it just like what happened in Chernobyl. Those people have a higher risk of getting cancers in general, not specifically prostate cancer. So when we look at risk factors, the major thing we need to say, especially for African American men, is that it is highest in African American men. So when we say highest, what do we mean? We mean in terms of incidence, it's happening. It's common if we compare the white, the Caucasian, and the African American, then it is more aggressive in the African American male compared to any other race. And that's also a non-modifiable risk factor. And I think that's important to note because it helps us to have a higher index of suspicion. So if we are health workers, it's good to think about prostate cancer. In my practice, I noticed many of the patients we found with prostate cancer were found in the orthopedic wards, meaning they had a fracture. They were just walking, minimal trauma. Somebody tells you, I was just walking, I slipped and fell, or I was getting up from the seat, I slipped and fell. And then you find the whole femur, very big bone, broke. and they're there on traction or being managed for other things, but we're not thinking about prostate cancer. So even just having minimal trauma and having fractures should be an indication of something is wrong with that bone. And maybe if we looked through, then it would be good to see it.
The thing about that, which is interesting, is the way men approach seeking healthcare and women approach seeking healthcare is totally different. For example, mwanaume yeye kuona his pee and like the place where his pee was going before has reduced, haitampeleka hosi, like until ashindwe kukojoa aone mkojo haitoki, there will be no raise for alarm. But now that's why we're making these videos where, like, if you see something that is out of the norm as a man, like your stream mkojo yako ilikuwa enda mbali imekuja karibu, kama ulikuwa na perform 5 minutes umeanza kuperform 3 minutes, hiyo ni time unafai kutafuta Dr. Wanda, unitafute mimi, utafute Laughing Lab Coats, tuongee hiyo agenda. Don't you think so?
I think so, and it's very unfortunate men are not able to discuss those issues. I saw a certain post on Twitter just a week ago, and somebody quite famous in the Twitter space was talking about, and he actually shared a screenshot of a man who had confided in him that he's having a reduction in performance. And first of all, the first things he got was a lot of ridicule, like, dude, like, seriously, you're fine, like, why are we discussing this, why are you telling a fellow man, why? So that just helps us see that men first are very shy to discuss those issues. One, because the population wouldn't listen. People don't want to hear a man saying that. They want the strong man. The perception is macho. So they don't want that to be described. I always say a man's self-esteem has a lot to do with him having an erection.
Performance.
Like waking up and having an erection in the morning is like so important. And when it's not there, the men are not able to cope. So anything that affects that sector is not something they would want to discuss. True. I remember working in an OPD, outpatient department, and I would know when a man wants to talk about urinary symptoms. He will talk about daktari hapa tumbo, and then daktari pia miguu, and they're just going around that area, and I'm like, okay, then I ask, so is there a problem? Unakojoa vizuri? Ama kuna shida yoyote katika sehemu ya siri? Mambo ya nyumbani iko sawa? So there has to be a way that conversation is made to feel normal, welcoming and warm, and understanding that this happens to other people. It's not unique to you is quite important. And definitely men would wait until they're in a lot of pain before they would come to hospital. Women would notice even the nail has changed color, and they would come at 3 a.m. in hospital to tell you, my nail has changed color, and it's like an emergency at that particular time. She noticed it and we have to address it. But for men, unless it stops them from working, unless it stops them from actually doing their daily life, they're not gonna bother about it. So I think it's important for men to know it is okay to talk about erectile issues. It's okay to talk about your prostate. It's okay to talk about noticing a decline in sexual function. It's okay. It happens, and the earlier we can get it, the better. We can treat it. Manage. Exactly. There are people who felt that way. Some have even gone to almost zero performance, and they've gotten assistance, and they're back to where they were, or maybe even better than what they were. Exactly. So I guess it's just to know it happens. Awareness. Yeah, it happens, but there's what we can do about it.
Probably the prospect of BRE
scares us.
By
the daktari, sasa, for example, now, if you were to advise the general Kenyan men population, what danger signs would you advise men to come look for a healthcare practitioner or an oncologist? What things would you make them highlight for? Because early diagnosis, I find, is a guardian angel when it comes to cancer management. The earlier you find the cancer in the earlier stages, the easier it is to manage for you as an oncologist, right? So what type of danger signs in prostate cancer would you highlight for men, that these 1, 2, 3, 4, 5 or 1, 2, 3 pointers that if you see are different for you, your sexual health and your reproductive health, you should look for a healthcare practitioner for further analysis?
So, well, I would start by saying, one, if you notice your urine stream is reducing in where it's going, then you need to get help. If you're noticing your sexual function is going down, you need to get help. If you have pelvic pain, back pain, chronic back pain or lower abdominal pain, you need to get help. If you have a relative that is close, like a father and brother who has had prostate cancer, then we'll take your screening very different from the general population that you need to look out for. So those are like some of the things you need to look out for and be aware. And I think we do not have a very strong strong screening culture as Kenyans. We don't go to hospital just to look for a problem. Anytime I get a chance, I say this. We make hospitals like the police station. It's very unlikely that someday you'll just pass by the cops and say, hi, guys, hi. I'm just here to greet you guys, I just want to know, do you think I have a problem? Do you think my tires are okay? But you see, it's very different because a car is something you can replace, but your body, you can't. And if we can notice a problem early, then we can actually ensure that it's... When you talk about stage 4 in most cancers, we're talking about a disease that has left the prostate and gone to a totally different organ. So maybe you have prostate cancer, but you also have lesions in bone. That is a sign of prostate cancer. Or you have prostate cancer and we're noticing lesions in the brain. You see, those are totally unrelated organs put in place. And now when we see a tumor in that area, then we know, okay, it's the same disease, but it has broken off from the prostate, going into circulation and gone to somewhere very far from where the tumor began. So that's pretty much the staging. And many patients and many relatives know about staging, but they always just want to know if they hear stage 4, then they think the patient is dying, which is not necessarily true. Being a stage 4 patient just tells the doctor that the tumor is just not within where it was. It's not locally there. It has gone to another organ. But we have very many patients who've been stage 4 patients, have very good quality of life, have not died many, many years from their diagnosis. It's not to say that they have, if we compare the prognosis, it's better when we catch it early. But stage 4 also doesn't mean automatically when you say stage 4 equals death. No, that is not a correct sentiment. So just being diagnosed with stage 4 should not make one feel like it's the end of the world. No.
That's really wonderful. Now, if you now have found a patient with those different stages, how do you approach it management wise based on those different stages?
So I guess what we need to understand is that how we even get to a diagnosis of prostate cancer. So first, if we notice there is a lesion, you can do imaging, and the imaging can either be an ultrasound or can be an MRI. That will tell us that there is a lesion within the prostate that is suspicious. But until we get a small piece or a small biopsy specimen removed from where the tumor is, we can't quite say someone has prostate cancer. We really have to get a small piece, it be taken to the lab, the pathologist to process the specimen, look at it under the microscope and confirm that we actually have cancer cells within it. So that is step number 1 before even we get to staging and decide the treatment options. So we like to catch it early because we have very many things we can do. And majority of the times we don't have to combine treatment modalities. You'd find one treatment modality would suffice. For example, surgery alone might suffice for very early disease. Surgery or even brachytherapy, where we insert seeds that have radiotherapy within the prostate to kill those cells locally, meaning we're just treating the local area, reducing the side effect profile a patient would have. Those are options that are possible at that stage. Where now it's maybe locally advanced disease, then we're talking about having a combination of modalities. So depending on the stage that we will notice you're at, we look at the Gleason score, we look at the grading of the tumor, then we do what is called risk stratification. And guidelines are very clear. If it's very low risk, then you can be able to do what is called surveillance, meaning the patient comes for serial imaging, just to see how the disease is progressing before we put active management to it. If we are having high risk, then we need to put treatment modalities. We are able to start with hormonal modulation. There are times we may decide to start with chemotherapy based on the bulk of the disease. If it's a heavy load of disease, we decide to give chemo to mop up the disease and sort of have it locally available. And then we have radiation that can also be put in place. So we can do hormonal modulation, shrink the tumor, and then give local treatment like radiation. For metastatic disease, where we mean the disease is in the prostate and in another organ, maybe bone. If it's gone to bone, then we'll need to give chemotherapy and then perhaps hormonal suppression. Because one of the things about prostate cancer is it's highly hormone driven. So the higher the testosterone levels, the higher the disease can be able to populate and spread and perhaps even go on causing more symptomatology. So it's very important for us to ensure the testosterone levels are low. So for metastatic disease, we'll do chemo just to mop up the disease. Then we can do hormonal manipulations. There are times the hormonal manipulation is sufficient, but then after a while we get what is called castrate resistant. So we've done everything to lower the testosterone levels, but the testosterone levels are still rising. And that tells us that now it's castrate resistant. Medical castration is not working. And now we have to think of other treatment modalities. And in that case, in point, we would change treatment now, maybe from the hormonal, give other treatment modalities that are there to just ensure the disease is not continuing to be fueled.
Interesting, Doc. Now, you mentioned something about chemical castration, and I remembered when I was in KNH, we used to do the prostate cancer clinic with Dr. Kimani. I don't know if you know Dr.
Yes,
Kimani.
I know DK.
Dr. Kimani is amazing. I really had an amazing time learning from him. He actually treated me when I had some conditions personally, and he's a wonderful doctor. So there's this mzee who came to us, and the mzee, he's married a young wife. And
which
Dr.
is always
Kimani,
almost the case in Kenya. They get to an age and you're like, I think I need a new wife. And she must be younger, you know?
She must be younger than my daughter sometimes, which is confusing. So Zaya amekuja, and the thing is, he's saying I have a young wife, but hii kitu haisimami, kiboko haisimami. So most people might not understand what you mean by chemical castration. So tamsulosin and finasteride, na hiyo ingine itwa do fasteride or something. Those drugs might lead to erectile dysfunction themselves.
Not necessarily, not the treatments you've actually mentioned. Perhaps the Casodex, the Zoladex, the ones we are putting in place to lower testosterone levels. Remember, testosterone is what is a male driving sex hormone. And that helps the man. If you're a teenager, you break your voice, you get beards, it ensures your breasts don't grow. And that sort of gives you the male characteristics because testosterone is on high. So in this situation, we want to lower testosterone levels. We want to ensure they are low so that we do not fuel the disease. So what happens is some men are able to notice a change in their sexual drive during the period on treatment. That is noted. However, we just don't leave you like that and say, yeah, you know what, cool, that's just the treatment. There are certain therapies that we do put in place. We have doctors and counselors who specialize in sexual therapy to be able to help the couples have a good active sexual life despite the fact that the patient is going through treatment. So that shouldn't be a fear that should make someone not want to come for care, because yes, it's the duration we're giving you treatment and we are not letting it go like that. We are also catering for your sexual health so that you're able to function and your family unit does not break. I know most patients come and tell me mambo ya nyumbani imeharibika kabisa. So when they say that, it's not the house that has a problem. It's not the compound. It's just the sexual issue in the family is not working. And sometimes it's really unfortunate because men are not able to explain. And most women imagine that the man must have had sex with someone. So he's not having sex with me because he's having sex with someone else.
Na ashachoka.
Achachoka. So anakuja kwangu amechoka, amepeana nguvu kwingine. So it becomes a very huge conversation. And sometimes we encourage the men to bring their wives to the clinic and they're able to ask those questions. So the man would say, and daktari, do these drugs affect sexual health? And then yes, we would say yes, and it can make someone not want to have sex. And then the wife says, oh, the sababu itishangi, and then now you realize you have actually sorted a family issue that they were not able to discuss at home. So we always encourage their spouses to accompany them so that we can understand, they can understand what the man is going through. They can be counseled on how to deal with the man, to understand his feelings, his thoughts. Sometimes they're very annoyed, they're very frustrated just because cancer is a frustrating disease. And sometimes when they're not able to channel that energy in a good way without therapy, then they project to their family, causing a strain in the family ties, which we try to address with therapy.
That's really smart, Doc. So I think I finish off and like go to our final part. This has been very informative. I have learned a lot and I'm a doctor. I haven't specialized in oncology. So I know the people who are watching are going to learn a lot from this video. We thank you very much for coming. Now you are in leadership in healthcare from all the things that you are doing, educating the government, educating the general public. What do you think is the government's role in combating prostate cancer? Is the government doing enough, or can they do more to improve the chances of survival of the everyday mwananchi, not those well off, the middle class, wale watu wenye wako in the dugouts, in the streets, working mjengo jobs?
So I think the government has a role, no? Because systems creation is something the government must look into. And I'm really looking forward to seeing what the new insurance scheme has in place. Previously, we had a lot of challenges for patients because screening was not paid for, biopsies were not paid for. So it was really expensive to get a diagnosis of cancer. So when I look at what they're saying the insurance would have in Kenya, they're talking about incorporating screening into the universal health coverage, meaning you'd not have to pay for that service. So it eliminates the barrier of cost. It eliminates the barrier of people fearing that if I get to know about cancer, I don't even have the money to start with the treatment. So now when that fear is off the mind, it's going to enable people to come for these services. So it will make our work easier. So these talks are going to make much more sense because then people would come for the service.
Exactly.
The government has a role in ensuring accessibility for these services. I think they've done, before I trained as an oncologist, and where we are today is very far. By the time I started training, the only places we had radiotherapy was Kenyatta National Hospital, KU, and the private facilities. During my training, MTRH Eldoret has begun. Nakuru has radiotherapy services, Garissa, Mombasa, So that tells you the government is trying to put in place areas close to home so that people don't have to travel. So you can imagine someone who travels from Garissa to Nairobi, Mombasa to Nairobi, Wajir, Lodwa, all those places, Turkana, they would have to come very far. So this dissemination of these services has been key. We have many more facilities that are able to offer chemotherapy. We have Meru that's offering chemotherapy just as a service on its own. And that's really amazing because it means we are having accessibility. There's a training program by the University of Nairobi to train oncologists in Kenya. That's like a marvelous step because it means the gap we've had for oncologists will soon be a story of the past. True. So I think we're doing very well. They're doing well. However, that doesn't mean there's no room for improvement. Even in the centers that we have machines, we need more machines for radiotherapy. We still need more centers for chemotherapy and more awareness creation. Because if you just walk on the street and ask someone about cancer, majority have no idea.
Yep, and majority say it's a death sentence, it's a terminal illness, it's a problem.
Yeah.
But now with this session that we are having and multiple sessions that healthcare providers can indulge and conversate to the general public and find solutions to these answers. Yeah. So thank you very much, Daktari.
Thanks for having me over.
Yeah, we really enjoyed this session. Hopefully we can have your social media page and we'll tag you here for you and your new followers who are going to find you and who are going to want to learn from you, get to connect with you. If they have any cancer patients or cancer issues that they might want to hear from you can get back to them.
Yeah, cool. Thanks very much. Have a good one.
Thank you, Daktari.
What to everyone who is watching?
So for everyone who's watching, I think it's important to note that cancer is not a death sentence. We have a huge population of persons who've had cancer, have been treated and doing very well, and that should be noted. Let us not fear to go for screening. The earlier we catch these cancers, the more we can do, the more the treatment options. And treatment is available within Kenya. We don't have to travel too far for it, but it's doable. A diagnosis of cancer doesn't change your life.
Thank you, Dr.
Peace out. Laughing Lab Coats.